Peter, thank you for introduction me, and it was an honor for me to be a part of the group working on women guidelines, and I hope that our results will help our colleagues in everyday practice. To my lecture today, we heard in previous lecture about the risk factors for a stroke in women. I will continue with the next one. Please, next slides. Next. Next, what we could do to decrease the number of stroke. Please, next slide. To decrease the stroke, the severity of stroke, to decrease mortality, and to improve the quality of life of women. I think that the answer is very simple. We know the risk factors, so we should treat them, and we should continue in improving it. Next slide. Next slide, please. Thank you. What about, this was the goal of Tracy Madsen, who studied the differences in the risk factors in women and how they are treated. So what was found? They found that hypertension is the risk factor in older women, but we can see that mainly older women are less likely treated by antihypertensive drugs. We know about atrial fibrillation, that it is the risk factor of stroke in women. But again, women are less likely to be prescribed oral anticoagulants, to have cardiac ablation. And about the next risk factors, the data about diabetes and the dyslipidemia are conflicting, if there is difference between men and women or not. But again, in women, women are less likely to be prescribed statins, and they have a worse control of the cholesterol. Next slide. As I mentioned, atrial fibrillation is the risk factor for severity of stroke, for mortality, and we can see on the right side that the highest risk factor it is for stroke. When we want to decrease the risk of stroke in patients with atrial fibrillation, at first we should, or patient at first should visit a doctor. Next. Next, please. Patient should visit a doctor, and it was the goal of the study of authors who presented data about Medicare beneficiaries in the US. And we can see that again, women less likely visit electrophysiologist, cardiologist, and the consequences are clear. When they did not visit the doctor, the prescription of rate control medication, rhythm control medication, catheter ablation was again lower in women, and again women less frequently used anticoagulants compared to men. Please, next slide. Registries are a very useful source for data to study patients from real life. We know that in randomized control trials, we have patients who are selected, and they are not the same as we have in the real life. And from National Cardiovascular Data Registry in the United States, the colleagues analyzed patients with newly diagnosed atrial fibrillation, and the patients who were included in this analysis were patients with more severe stroke, as we can see from the CHAT score. Next slide. And I think that the results were not surprising, because we know from everyday life that patients with atrial fibrillation are undertreated with oral anticoagulants, and it was the same in this analysis. And 40% of patients used aspirin alone, even though they met the criteria for oral anticoagulation. Again, despite the factor that women have atrial fibrillation as a risk factor more frequently than men, women were less likely to be treated by oral anticoagulants compared to men who had a higher odds ratio for treatment with anticoagulants as the prevention of the stroke. Next slide. One problem is that women are undertreated with oral anticoagulants, but the second problem is that in a lot of patients, the dose of the anticoagulants is decreased without any reason. And the problem with women was about the dabigatran, because in some studies it was found that there are higher levels of plasma levels of dabigatran in patients treated with dabigatran, and that is why it was a recommendation done by some authors to reduce the dose of dabigatran in women. But the analysis which was realized in Canada compare patients who were treated with aspirin and with dabigatran, and we can see results. Next. When they compare patients treated with warfarin and dabigatran, there was no difference between patients. What about the stroke events? But they found that dabigatran has less frequently bleeding complications, what is not surprising. We know it that new oral anticoagulants are more safe than warfarin. But what was interesting that lower dose of dabigatran had higher risk of bleeding compared to dabigatran 150 milligrams. And we can do conclusion from this that not plasma level of dabigatran is important, but it is important the outcome. And we can see from this study that outcome of patients treated with higher dose of dabigatran was better than patients treated with lower dose, and there is no reason for the reduction of the dose of dabigatran in women for future. So not only drugs, but also the dose of the drugs is very important for the prevention of the stroke. Next slide, please. Here we can see the representation of the women in the randomized control trial, and the women are blue in this picture, and we can see that they were underrepresented in all randomized control trials. And it is the question, is it only in randomized control trials, or is the real life? About this will be the next lecture. And now I will speak a little bit about the arterial hypertension. Next slide, which is the second risk factor of stroke in women. On the left side, you can see that the distribution of the hypertension in different ages is similar between the men and women. Maybe women are a little bit have a little bit higher prevalence of arterial hypertension. But the interesting is the right side, when we can see how arterial hypertension is controlled in the patients with hypertension. And when we can see the right column, the best treatment of hypertension in women was between 40 and 59 years of age. But we see that in women over 60, the hypertension was worse controlled than in younger patients. And we know that the older women are at higher risk of the stroke. It is the question, what does it mean over 60? Because over 60, it can be 70 and it can be 90 or 100. It was not analyzed in this article. but because it is the question if it is influenced only that women were very old and in the terminal stage of the disease, or they were younger, because 70, 80 years of age women should be treated as it is recommended. Next slide, please. Cheryl Carcel is a doctor who deals with differences in women a very long time, and she published a lot of articles on about this topic. And also in this article with the co-authors, they presented sex differences in treatment and outcome after stroke. They analyzed nearly around 19,000 participants. And next slide, please. And they analyzed 5 randomized control trials where representation of the women was about 40%. And again, the results are not surprising when we compare it what we heard before. The medication at admission was worse for women when we compare anticoagulant, antiplatelet, glucose lowering and lipid lowering drugs. You can see on the graph that women were less likely treated like men. And what about the secondary prevention? Then in secondary prevention, antiplatelets were used similarly, but antihypertensive agents were less likely used in women compared to men. And next slide. What about the other results? Women had higher survival at 3 or 6 months, but with the worse quality of life. And I think that it should be our goal not only to prolong survival, but to improve the quality of life. And the quality of life was studied in the next study. Next slide, please. Again, we have the data from the registry. The Get With the Guideline Stroke registry is a US registry of the patients with the stroke. And they predefined performance measures for measurement of the quality. 3 of them were for acute treatment, and then 4 discharge performance measures. Women who were included in this analysis were older. They have a higher history of atrial fibrillation and arterial hypertension. And what is the result of this quality analysis? Next slide, please. Again, we found that women had worst acute treatment. It was found that intravenous alteplase was used in a window 2 hours less likely in women compared to men. And again, anticoagulants and lipid lowering drugs were used less frequently in women. And very interesting are the last 2 rows about the detected free measure and composite measure. When they analyzed the quality of care in patients, and it was found that in women there was a lack of some activities which should be done for the better outcome of the patients with the stroke. So from all what I told before, next slide, we can, and it was in all age levels. Next slide, please. From all what I told before, we can make the conclusion that there are 6 differences between the risk factors, but exist also the sex differences. What about the treatment? And it's time to change it, because our goal should be not only to prolong the life of the women, but we would like that the women are living long and in a very good quality of life. Like, for example, this lady who is around 85 years of age. And I apologize for my voice, but I am at the end of the COVID infection, so I'm sorry.